everything that matters.
A whole shebang.
Exactly. You aren't just going to put a simple padlock on the door. You're going to build a fortress.
Right. Bank vault doors, laser grids.
I'm talking walls thicker than a bank vault, air filtration systems that catch individual molecules, and a security detail that doesn't just check your ID, it checks your atomics structure.
It sounds like you're pitching a high-stakes heist movie, but knowing you, I have a feeling we're actually talking about anatomy.
We are. I'm talking about the central nervous system, the CNS.
The command center.
Your brain and your spinal cord. It's the command center for literally everything you are and everything you do. And biologically speaking, the body treats it like the ultimate VIP.
It definitely does.
It's got the skull, the vertebrae, and then that legendary velvet rope we always hear about, the blood-brain barrier.
Which is, under normal circumstances, just a biological marvel of isolation. It is incredibly effective at keeping, toxins, pathogens, and wild chemical fluctuations from the blood away from your delicate neurons.
It's a closed loop.
A completely closed loop.
Exactly. But today, well, we aren't celebrating the security system. We are doing a deep dive into what happens when that system fails.
When the fortress is breached.
A catastrophic breach. We're talking about an invader that picks the lock, scales the walls, and effectively sets the building on fire from the inside. We are talking about meningitis.
And we need to be really clear right off the bat. This isn't just a condition or an illness. In the world of infectious disease, meningitis is a 5-alarm fire.
A true medical emergency.
Absolutely. It's an infection of the fluid and the membranes, the meninges,
Yeah.
that surround and cushion the brain. And the source material we're looking at today, it paints a terrifying picture. It's a race against time where, tragically, the body's own defense system might actually be the thing that deals the fatal blow.
Yeah, that part is staggering. We've pulled together a massive stack of medical literature here, covering everything from pathophysiology, how these bugs actually pull off the heist,
All the way to the pharmacology.
which is basically the chemical warfare we use to get them out. So if you've ever wondered what happens when the body's Mission Impossible scenario actually plays out in real life, you're in the right place.
It is a fascinating, albeit very high-stakes, biological battleground. There's a lot of nuance here that often gets missed in the headlines.
Okay, so let's start with the invasion itself, the breach. You mentioned the blood-brain barrier. I always picture this as a solid wall, like saran wrap around the brain. But bacteria are getting in. How are they burning through, teleporting?
Not quite teleporting, no. Though the biology is almost as sophisticated. Based on the literature, these pathogens have evolved basically 3 specific entry vectors.
Okay.
The most common one is what we call hematogenous spread.
Which is just fancy medical talk for traveling through the blood, right?
Precisely. The bacteria usually start somewhere else, somewhere almost mundane. Maybe a primary infection in the lungs like pneumonia or in the throat.
So not in the brain.
No, not at all. They hitch a ride in the bloodstream. Now, normally the blood-brain barrier would just stop them cold. But if the bacterial load is high enough, if there are just too many of them, they can overwhelm the defenses and cross over.
So it's a numbers game, a brute force attack.
Partly, yeah. But it's also about proximity. And that leads us to route number 2, seeding from a parameningeal focus.
Parameningeal. So that means neck to the meninges.
Exactly. Think about the real estate inside your skull. It is incredibly crowded in there.
Sure.
Your ears, your sinuses, they're basically sharing a wall with your brain. So if you have a severe ear infection, what we call otitis media or bad sinusitis, the bacteria can sometimes just erode right through the bone or travel along the veins to cross into the CNS.
Wow. So it's like a fire spreading from the apartment next door because the walls are too thin.
That is a perfect analogy. And the third route is, well, the most direct and brutal: trauma or congenital defects.
Okay.
If you have a skull fracture or you've had neurosurgery, you've physically broken the wall. You've just left the back door wide open for anything to walk right in.
Speaking of open doors, the sources mentioned some risk factors that I found really specific. I mean, we all get skull fractures, sure, but there was a note about cigarette smoke that really surprised me.
Yes, that is a significant one. And it's not just if you smoke.
It's passive, too, secondhand smoke.
Passive exposure, absolutely. It significantly increases the risk of bacterial meningitis.
How does smoke in the lungs affect the brain's security system? That feels like a big leap.
It's all about the first line of defense. Smoke damages the cilia, those little microscopic hairs in your respiratory tract that are constantly sweeping out junk and bacteria.
Right, the little
The
janitors.
little janitors, exactly.
Hmm.
It also damages the lining of the throat. So this makes it much easier for bacteria to set up shop to colonize, which is the absolute prerequisite to invasion.
So if the bouncer at the front door is asleep, the bad guys get into the club.
That's it. And there was one other highly specific risk factor you pointed out, cochlear implants.
Yeah, that one seemed to come out of left field.
Specifically, it's implants that use a positioner. It's a component used in some of the older surgeries. The data indicates that having this foreign body that close to the CNS creates a little niche, a hiding spot for bacteria to grow.
It's a bridge.
It essentially creates a bridge that bypasses all the natural barriers.
It's wild that something meant to restore a sense hearing can inadvertently create such a major vulnerability.
It really is.
Okay, so we know the routes, but let's zoom in on that first step. You mentioned colonization. Walk us through the mechanics of this heist.
So before the bacteria can even think about invading the brain, they almost always have to colonize the host. This usually happens in the nasopharynx.
So the space behind your nose?
Right. The bacteria attach themselves to the epithelial cells there.
So they are just kind of loitering in the back of your throat?
For a while, yes. But the critical moment is when they move from just sitting on the surface into the bloodstream. They get phagocytized.
Engulfed.
Engulfed, exactly, by the host's own cells and then transported into the blood. Now, normally, once bacteria hit the blood, the immune system's belief, the neutrophil, should spot them and kill them immediately.
But these guys survive. They're swimming in a river of immune cells and not getting caught. How?
They do.
Yeah.
And this is where the invisibility cloak comes in. The major culprits, we're talking Haemophilus influenza, E. coli, Neisseria meningitis, they all share a secret weapon.
The polysaccharide capsule.
Correct.
Okay, let's unpack that. Because I see polysaccharide capsule in the notes, and my brain just translates that to sugar coating. Why is a sugar coating a weapon of war?
It's a great question. Think of the immune system like a security team that needs to tag intruders. Usually, your body uses a process called opsonization.
Right.
It coats bacteria with proteins that act like handles, or bright neon eat me signs for your white blood cells.
Mm-hmm. So the neutrophil sees the sign, grabs the handle, and it's game over for the bacteria.
Precisely. But this polysaccharide capsule is incredibly slippery. It's chemically neutral. It prevents those tags, those opsonins, from sticking.
So they're wearing a Teflon coat.
That's a perfect analogy. It resists opsonization.
Mm-hmm.
It essentially makes the bacteria invisible, or at least very, very hard to grab, for the immune system. It's like trying to catch a greased pig.
So that's what lets them circulate in the blood in massive numbers without being destroyed.
Exactly. It's stealth technology. They bypass the initial security checkpoints, but then they reach the brain. They cross the barrier. And this is where the story takes a really dark, almost paradoxical turn.
Yeah, the source material had this aha moment for me. I always assume that meningitis damages the brain because the bacteria are literally eating the brain tissue.
A very reasonable assumption. But it's incorrect.
It's actually our fault, isn't it?
It is the great paradox of meningitis. The neurological damage, the reason people die or suffer permanent disability, is largely caused by the host's own inflammatory response.
We are destroying the village in order to save it.
In a way, yes. Let's trace the cascade because it is just terrifyingly efficient.
Okay.
The bacteria enter the CNS. Eventually they die, either from our antibiotics or just natural turnover. When these bacterial cells die, they lyse, they break apart.
They explode.
They explode, and they release all their cell wall components.
It's just debris.
Toxic debris. If it's a gram-negative bug, they release lipopolysaccharide and lipid A. If it's gram-positive, it's peptidoglycan. This debris acts like a tripwire.
For what?
It triggers the endothelial cells and macrophages in the brain to just freak out and release a flood of cytokines, things like interleukin-1 and tumor necrosis factor.
I've heard of those. Those are the immune system's alarm bells, the air raid sirens.
They are chemical air raid sirens. And what do they tell the body to do? They scream, "Open the gates! We need troops in here, now!"
And the gates are the blood-brain barrier.
The very same barrier we just praised for being so tight and secure. The inflammation causes the tight junctions between the cells to loosen. The capillaries become leaky.
Leaky pipes in the brain. That sounds like an absolute disaster.
It is catastrophic. Fluid starts pouring out of the blood vessels and into the brain tissue. This causes cerebral edema swelling.
Okay, but here's the physics problem, right? The brain is inside a rigid bone box. The skull does not expand.
It doesn't give it all.
So if the brain swells,
The pressure has nowhere to go but up. Intracranial pressure, or ICP, skyrockets. It starts to physically squeeze the brain structures, and when that pressure goes up, blood flow goes down.
the pipes get crushed.
They get crushed. You get cerebral ischemia. The brain is starved of oxygen, and that is what causes the permanent damage and death. It's the swelling and the loss of blood flow, all driven by our own immune reaction to the bacterial debris.
That is just, it's heavy. The battle causes the collateral damage that takes down the fortress. It's a biological tragedy of errors.
It really is.
So knowing that the storm is brewing inside, how do we spot it from the outside? This brings us to section 2, the red flags.
The clinical presentation. And this is really tricky territory.
Right, because everyone learns the classic triad in medical school, right? Fever, neutral rigidity, stiff neck, and altered mental status. The textbook says if you have those 3, you have meningitis. Case closed.
If only medicine were that simple. The reality is much, much messier. While those signs are classic, the literature really emphasizes that they aren't always present, especially not altogether. If you wait for the full triad to appear before you act, you might miss the diagnosis entirely.
And what about those other famous signs? Koenig and Brzezinski.
Ah, yes.
They sound like a detective duo from a 70s cop show. This week on Koenig and Brzezinski.
They're actually physical maneuvers we use to test for meningeal irritation. Koenig involves straightening the leg. Brzezinski involves flexing the neck to see if the knees pull up.
But how reliable are they?
And here's the major caveat. The literature explicitly states they're poorly sensitive.
Meaning you can have full-blown meningitis and still pass those tests with flying colors.
Yes. They are frequently absent, especially in very young children and in the elderly. Relying solely on them is a trap.
And speaking of children, the age factor seems huge here. The sources say the younger the patient, the harder it is to spot.
That's a general rule in pediatrics, but it is absolutely critical here. Infants and young children often present with very atypical symptoms.
So no stiff neck.
They might not have a stiff neck at all. Instead, you have to look for something like a bulging fontanelle.
That's the soft spot on a baby's head, right?
Right. Because their skull bones haven't fused together yet, that rising intracranial pressure can push outwards. You might see the soft spot physically bulging.
Right.
Or you might see apnea. They just stop breathing for periods of time. Or they're just incredibly lethargic. Or have this strained, high-pitched, inconsolable cry.
So for a baby, it's not, my neck hurts. It's more like, I'm just not right. I'm barely responding.
Exactly. And then there's the skin. We absolutely have to talk about the rash.
The rash seems like the biggest, brightest red flag of them all.
It is the siren. We look for purpuric or petechial skin lesions. These are little purple or red spots that look like bleeding under the skin.
And there's a key test for this, right? The glass test.
Right. A normal rash will blanch. It'll turn white or fade if you press a clear glass against it. These don't.
They stay red.
They stay red or purple. That means the blood is actually leaked outside the vessel and into the skin. It's a sign of sepsis.
And if you see that specific rash, what does it tell you?
It strongly, strongly points to Neisseria meningitidis, meningococcal meningitis. It can happen with Haemophilus influenza, but it's very rare with Streptococcus pneumonia.
So fever plus that specific non-blanching rash.
If a patient comes in with that, your alarm bells should be screaming for meningococcus. You are minutes, not hours, away from a catastrophe.
Okay, so you have a patient, maybe they have the stiff neck, maybe the rash, maybe just a bulging soft spot in a baby. You suspect the breach. Now you need proof.
Now for the detective work.
Section 3, diagnosis.
And the gold standard here, without a doubt, is the lumbar puncture, or LP.
The spinal tap, going directly to the source.
We have to sample the cerebrospinal fluid, the CSF. We need to see what's actually floating around inside the fortress.
But there's a trap here, isn't there? The antibiotic trap.
This is a really common dilemma in the ER. Ideally, you tap the spine, get the fluid, and then you start the antibiotic so you know exactly what you're treating.
But you can't always do that.
No. Sometimes doing the LP takes too long. Maybe the patient is unstable, or they need a CT scan first to make sure their brain isn't swelling so much that a tap would be dangerous.
Yeah.
You cannot wait to treat.
So you have to give the antibiotics first.
You absolutely have to. But if you give antibiotics before the LP, you might sterilize the fluid. The bacteria stop growing.
So when you send that fluid to the lab for a culture, it comes back negative.
It can, yeah.
So you've treated the patient, but you've destroyed the evidence of what the bug was. You're flying blind.
To an extent. But here is the crucial nuance from our source material. Antibiotics might kill the bacteria quickly, but they rarely affect the CSF protein or glucose levels that fast.
Ah.
The chemical signature of the infection remains, even if the bacteria are dead.
Okay, so let's read the tea leaves. You get the fluid. What does bacterial meningitis look like by the numbers?
You're looking at three main things: white blood cells, WBC, protein, and glucose.
Let's start with white blood cells.
First, WBCs. Normal CSF has less than 5 cells per microliter. It's very clean. In bacterial meningitis, you are often looking at 1,000 to 5,000. It's a massive immune mobilization.
The fluid must look totally different.
Oh, it does. It might literally look cloudy or milky. It's full of pus.
That's a huge jump. What about protein?
The bacteria and the inflammation from the leaky barrier, they both leak protein into the fluid. Normal is low, under 50 milli-GDL. In bacterial meningitis, it's elevated. The text notes that a level of 80 or higher is a significant risk marker.
And finally, glucose. Sugar. This one seemed the most counterintuitive to me.
This is a key differentiator. Bacteria are living things, and they need to eat. They consume glucose as fuel.
Right.
Plus, the inflammation itself can interfere with the brain's ability to transport more glucose in from the blood. So in bacterial meningitis, the CSF glucose is characteristically low.
How low is low?
The rule of thumb is the ratio. You always check the patient's blood sugar at the same time. If the CSF glucose is less than 50% of the peripheral blood glucose, that strongly suggests bacterial meningitis.
So if my blood sugar is 100 and my spinal fluid sugar is, say, 30.
That is a major, major red flag for bacteria. Viral meningitis or fungal meningitis have different profiles. Viral usually has normal glucose. Bacteria eats the sugar.
So it's like tracking a thief by seeing what food is missing from the fridge.
That's a great way to think about it.
But we have high-tech options now too, right? What if the culture is negative because you gave the antibiotics first?
Yes, then we turn to molecular forensics, PCR polymerase chain reaction, and antigen tests. These look for the DNA or specific proteins of the bacteria themselves.
So it doesn't matter if they're alive or dead.
Doesn't matter at all. They can identify N. meningitis, S. pneumonia, or Hyatt beak, even if the bacteria are dead and won't grow in a culture. It's been a game changer.
It's CSI for the brain. Okay,
Yes.
let's say we've confirmed the breach. We know it's bacterial. Now we have to fight back. Section 4, the counterattack. What is the golden rule here?
Speed is life.
Don't wait.
Never, ever wait. Empiric antimicrobial therapy must start immediately. If you are even thinking meningitis, you start the drugs.
Before anything else.
Do not wait for the LP results. Do not wait for the CT scan if it's going to cause a delay. A delay of even a few hours can be the difference between a full recovery and death or permanent brain damage.
So you shoot first and ask questions later.
Exactly. We start empiric therapy, these broad-spectrum weapons that kill the most likely suspects, and we keep that going for 48 to 72 hours until we can identify the specific bug and tailor the treatment.
But here's the problem we touched on earlier. The blood-brain barrier. It's designed to keep things out. Doesn't that make it incredibly hard to get antibiotics in?
It does. It's a huge pharmacological challenge. Many drugs simply cannot cross a healthy blood-brain barrier. They're too big, or they're not lipid-soluble enough to pass through.
So how do we solve that?
But here is the great irony of this disease. The disease itself helps us. Remember the inflammation, the leaky pipes.
Right, the walls are breached.
That inflammation, that breakdown of the barrier, actually allows the antibiotics to penetrate better. As the meninges get more inflamed, they let more drug through.
Wow.
So in a weird way, the severity of the infection opens the door for its own cure.
That is a lucky break. Now let's talk about the steroids. This seems to be the most critical, most strict protocol in the entire document. The text highlights dexamethasone.
This is the make-or-break moment for minimizing the collateral brain damage. Dexamethasone is a potent steroid. We use it particularly for H. influenza in kids and for S. pneumonia in adults.
Why give a steroid? Isn't that suppressing the immune system? Don't we want the immune system fighting at full strength?
We do, but we need it to fight smarter, not just harder.
Yeah.
Remember the cascade.
Right. Antibiotics kill the bacteria explode and release toxins.
And the immune system freaks out, causing the brain to swell dangerously. We want to blunt that inflammatory spike. We want to kill the bacteria without the host destroying the fortress in the process.
So the steroid calms the riot police down so the antibiotics can do their job without everything being burned to the ground.
That's it, exactly.
Yeah.
But, and listen closely to this, because it's non-negotiable, timing is everything.
Okay.
The protocol states dexamethasone must be given 10 to 20 minutes prior to or concomitant with the first dose of antibiotics.
So before or at the exact same time, never after?
Never, ever after. If you give the antibiotics first, the bacteria have already started to lease, the toxins are released, the inflammatory cascade has started, the horse has already left the barn.
Too late.
It's too late. The text is very clear.
Oh.
If it's given after the first dose of antibiotics, it does remarkably little good and should be avoided.
Wow. So that first 20 minutes in the ER is this carefully choreographed high-stakes dance. Steroids, then antibiotics. Get the order wrong, and you lose the benefit.
It is the definition of high-pressure medicine. And of course, that's just the start. You have supportive care managing fluids, electrolytes, constantly monitoring that intracranial pressure. You have to keep the patient alive while the drugs do their work.
Let's talk about who we're fighting. The rogues gallery. Section 5 breaks them down by personality. Let's start with the heavy hitter.
Streptococcus pneumonia, pneumococcus. This is the leading cause of bacterial meningitis in anyone older than 2 months.
What makes it so tough?
It's stubborn. We see incredibly high rates of penicillin resistance with this bug. It has learned to evade our oldest and most reliable weapons.
So penicillin is basically off the table.
Often, yes. You can't rely on it. The strategy now is a combination attack. We typically start with vancomycin plus ceftriaxone, which is a third-generation cephalosporin.
A double tap.
The double tap. You have to hit it hard from 2 different angles. We use the vancomycin to cover those potentially resistant strains until we get the lab results back, what we call the minimum inhibitory concentrations.
And if the lab says it's susceptible,
Then we can scale back. But you have to start heavy. And of course, prevention is everything here. We have vaccines, the PCV13 for infants, the PPV23 for the elderly. They've made a huge difference.
next up, the scary one, Neisseria meningitatis.
The meningococcus. This is the one that terrifies college campuses and parents of teenagers. It specifically targets children and young adults. It is the leading cause in those age groups.
And it has a season. I saw that in the notes.
It does. It tends to peak in the winter or early spring.
We talked about that non-blanching rash, but the text mentioned a second wave of symptoms that I had never heard of before.
This is a fascinating immunological phenomenon.
Yeah.
About 10 to 14 days after the onset of the disease, so the patient might actually be recovering, the bacteria are gone.
The fight is over.
Seemingly. But then they can develop a reaction. Fever, arthritis, usually in the large joints like the knees, and even pericarditis, which is inflammation around the heart.
Wait, so the infection is gone, but the body is still fighting something?
It's an immunologic reaction to the antigen complexes, the debris that were left behind from the battle. It's like a delayed allergic reaction to the war that just happened in your body.
That is bizarre, and this is the bug where prophylaxis is a huge deal, right?
Absolutely. Because it is so contagious via respiratory droplets. Coughing, sneezing, kissing, sharing drinks. Close contacts need protection.
So roommates, family members?
Roommates, family members, anyone with close contacts. We treat them with antibiotics like rifampin, ciprofloxacin, or ceftriaxone to prevent them from getting sick, too.
Okay, next rogue. Haemophilus influenza. You called this one the fading giant.
It used to be the #1 cause of meningitis in young children, an absolute terror. But thanks to the high vaccine, which was introduced in the late 80s, the numbers have just plummeted. It's a massive public health victory.
But it's not gone completely.
No, not at all. And when it does strike, it has a nasty signature move, hearing loss.
It attacks the ears.
It attacks the auditory nerves. Unilateral or bilateral deafness can occur early or sometimes even late in the disease. So even if the child survives, there can be this permanent, devastating cost.
And finally, the silent threat. Listeria monocytogenes.
Listeria. This one is the outlier. It targets the very old over 65 and the immunocompromised. And biologically, it's a weird bug. It's a gram-positive rod, diphtheroid-like.
And the standard treatments don't work.
Correct. And this is a critical point. The cephalosporins like ceftriaxone, which we use for almost everything else, do not work well against Listeria.
So if you have an elderly patient.
If you have an elderly patient or someone with a weak immune system, you must add ampicillin or penicillin G to the empiric cocktail.
You have to cover for it just in case.
You have to. And you often add an aminoglycoside like gentamicin on top of that. They work together, synergy to kill the bacteria. This is why knowing the patient's age and risk profile is so vital. If an elderly person comes in and you just give them the standard young person cocktail, you will completely miss the Listeria and the treatment will fail.
That brings us to the final group in Section 6, the special cases. Gram-negative bacillary meningitis.
Right. This is usually seen in elderly or debilitated patients or after neurosurgery. And the problem child here is Pseudomonas aeruginosa.
I know Pseudomonas from other contexts. It's always the nightmare bug. It's notoriously hard to kill.
Extremely hard to kill. It requires our heavy hitter antibiotics, the extended spectrum beta-lactams, specifically ceftazidime or cefocampime. Regular ceftriaxone just isn't strong enough. And even then, we have to add an aminoglycoside like tobramycin.
But the text mentioned a last resort option for this that sounded incredibly intense: intraventricular administration.
Yes. If the bacteria are resistant to everything, or if the drugs just aren't penetrating the inflamed barrier well enough, we sometimes have to inject the antibiotics directly into the ventricles of the brain.
So you're bypassing the blood entirely and just putting the drug right into the fluid reservoirs inside the brain.
We are. But it's very tricky.
Yep.
The text notes that CSF flow is unidirectional. It flows out, not in. So even if you put drugs in the lower spine via a lumbar puncture, they won't float up to the brain ventricles where the infection is worst.
So you have to go right to the source.
You have to go directly into the ventricles with a catheter to get therapeutic concentrations right where you need them.
That is the definition of extreme measures. But I guess it just shows how desperate the fight can get when the fortress is breached by something that stubborn.
It does. It highlights the incredible difficulty of treating an infection in such a protected, sacred space.
So let's bring this all back together. We've looked at the invasion, the stealthy colonization, the explosive inflammatory response our own body creates, and then this high-speed chase of diagnosis and treatment. What's the big picture here?
The big picture is that the central nervous system it's a double-edged sword. Its incredible isolation protects it from 99.9% of all threats. But that exact same isolation makes it incredibly vulnerable when that 0.1% gets in.
The walls that keep intruders out also keep our help out.
Exactly. The walls keep medicines out. And the immune system that so brilliantly defends the rest of the body can literally crush the brain inside the rigid skull.
It's such a delicate balance. We have these powerful antibiotics, but we have to be smart enough and fast enough to manage the host response with steroids.
We have to be fast enough to beat the replication clock of the bacteria.
And we have to be vigilant enough to spot the subtle signs, the mist rash, the slightly bulging fontanelle before it's too late.
It's all about time.
It really makes you appreciate the blood-brain barrier. It's not just a piece of anatomy. It's this dynamic, intelligent gatekeeper. And understanding how it fails, well, that's the only way we can ever hope to fix it.
Absolutely. And you have to wonder, as bacteria continue to evolve resistance to our best drugs, that race against time is only going to get tighter and the stakes even higher.
A sobering but fascinating thought. That is going to wrap up our deep dive into meningitis and the war for the CNS. We hope you learned something new about the battle going on inside the fortress.
Stay curious and stay healthy.
We'll see you next time.